So I think the first take-home message from this presentation is that, as we know, when you begin our practice, we may not have the financial resources to have every gadget which is ideal to practice. But even if a simple auto K reading, you can start doing the toric lenses. The beauty of this thing is, the margin for error is quite significantly high. It is quite safe. You can always go ahead and start doing your toric lenses as and when your resources improve, you obviously can add all the gadgets. So first take home message is, even with your regular A scan with immersion biometry and good readings from your autokeratometer reading, you can start doing your toric lens implantation with excellent outcomes. So the next, once you decided that you're going to operate and put a toric lens, how do you measure or how do you mark? So this becomes the next more important thing. And as we all know, there are multiple techniques of marking on the cornea, including image guided devices. But I'm trying to be very simple and practical, which and every ophthalmologist who is doing cataract surgery can use these techniques. So, as we all know, the quality of the vision is extremely critical. That is the reason why we need to correct all these patients who have got astigmatism. As has been told, our threshold is, anything above zero point 0.5 against the astigmatism, we would always decide to go ahead with the toric lenses. Thankfully, in our country, we have an option of good intraocular lenses as well, which are much more economical and do a decent job. So, the cost of the lens itself should not deter you from venturing into toric lens practice. That should be the first take home message. And why do you have to be so conscious in getting your marking rights? The relevance is, the error can happen at every stage. So when we measure, they can have an error, calculation error, marking can error, and even during IL alignment, final alignment, you can have an error. So it can happen at every step. These are the 4 stages at which error can happen. So to keep it very simple, I want to simplify as much as possible. We are having 2 marks. One is the reference marking. That is, you want to have a 0, 180 degrees. That is a reference on which you're going to base your marking for the axis. The IOLs have a marking. IOLs usually have to be placed on the steeper axis. So to get everything right, you have to have a perfect reference marking, that is 0, 180 degrees. And most errors happen because of errors in this reference marking itself. So we need to ensure that to ask ourselves one question: are we marking 0, 180 degrees? Is it accurate or not enough? So one of the most common errors which can happen is head tilt when you're trying to mark at the patient's slit lamp or in the operation theater, freehand marking. The most common error which I feel is a little bit of head tilt which can be missed by a naked eye. And this is where we want to validate our reference marking using the gyroscope technology, and which is available in our smartphones. And thankfully we have got 2 excellent apps. Android, which I use, is iToric. Dr. Saurabh Patvardhan's here. He's here only. And people who are using iPhones, they can use Toricam, Dr. Barrett's app. And basically, what these apps tell you is that whether your horizontal reference marking is good enough or not. So, because that is the most important source of error. And I'll just show you, what is the best way to do it, or how I am going to usually mark my cases. So let me begin by showing you how we do it in the slit lamp. And this is a video which so basically, you have to anesthetize the patient at the slit lamp using local drops, and having a drier cornea ensures that you have a slightly thinner spot. So I'm using a 30 gauge needle. I prefer to use a speculum, and asking the patient to look ahead straight in the light. The light is 10 at 0 and 80 degrees. What I'm doing is switching between 2 eyes, so that ensures that head tilt is minimal. If it can cut across the Herbert reflex at both the times similarly, then we can know that your head tilt is minimized. Once you have this horizontal marking, then you are going to confirm by using the app, which I'm going to demonstrate. So ask the patient again. So what we're doing is, looking here, the patient's head is always stabilized by an assistant so that it doesn't move back. Most of these patients are old. They require some help to minimize this thing. And this is the slit lamp video, and this is an external photography. So I prefer to use a 30 gauge needle, and just use a superficial stromal puncture, not just a marking. So usually what we do is we go ahead and puncture the stroma so that it stays in for long. The idea here is the case may be sixth or seventh on a list, and by the time the turn comes, the ink mark can vanish off. But if you have a puncture there, the mark is always going to be there. This is other way of marking. It's the traditional way at the operation theater itself. Again, here I would like to ensure that because some of these patients would be squeezing. Best would be always to use a speculum to do that, and use a bubble marker to mark this. Again, you are going to use this app to confirm your how it is, whether the horizontal reference marking is accurate or not. And always my preference is always to do this app marking even at the slit lamp. So this is what I use. Again, the idea is the patient is sitting at the slit lamp with a good illumination. The head is stable. You get excellent photographs by using this. And you've got those rings, and the rings have to be, the largest ring has to be aligned with the external limbus. And then you have got calipers, which you are going to align with the mark which you've done. So what basically the app is going to tell is how much off axis are you really with the general 0 to 180 degrees. That is what we want to find out here. So by using this gyroscope device which is built in, we come to know how much off the axis it is. So usually if you're very good at it, it's seldom more than 1 to 2 degrees. But definitely using this app along with your marking at the slit lamp, it gives you excellent accuracy, which can be compared even with your imaging devices. So it's almost the thing would be, is almost the difference would be very negligible. So we are using this device, and it has provided us excellent outcomes. And I don't find much difference by using a compared to using an imaging device, which are quite expensive. Now moving on to the intraoperative alignment. Obviously, the most important aspect is once you're marked, the surgery is going to be extremely routine. You have to have the basic principles that you have to have a good rexus, very well centered rexus. That is the key, which is going to hold the lens in position. Most of the lenses which you have in the market are hydrophobic, where they're going to stick onto the capsular bag pretty well. And maybe once you go in, you can always re-enhance the marking, and you can use the implantation of your choice. Here I'm using hydroimplantation. Even if you use viscoelastic, it is fine, no problem. Only ensure that once you're done it, you empty the bag totally of the visco and the posterior surface of the lens, because viscoelastic inside the bag or behind the posterior lens, that can cause the lens to move around a little bit. Just ensure that you don't have any viscoelastic at the back, and then you align the lens appropriately. The only, usually these lenses stick on very well. I haven't had much experience of rotation post-operatively, especially the hydrophobic lenses. Now, once you do it, it's important that you tap the lens posteriorly and ensure that the eye is a little bit soft, so that the apposition between the posterior capsule and the posterior surface of the lens is there, so that it sticks on quite well there. So I have not, in my experience, noted a significant rotation. I have been following them for quite some time. And even if rotation happens, it usually happens in the first 10 days, maybe first day itself, the maximum rotation happens. So if you are having any abnormal refraction the first post-op day, always go ahead and try to dilate the pupil and see whether the lens is sitting in the intended axis or not. So this is what in a dilated examination, maybe after just 1 week or so, you're just trying to dilate and see whether the axis it is holding on to the area where it is there or not. The most important aspect is, when in certain situations, like when patients were having myopia, who have a large bag, those are the situations where I would use a CTR in the place. The idea of using a CTR in these eyes which have got large bags is to ensure, one thing is it stretches the bag. it brings the posterior capsule forward a little bit. The adherence between the posterior surface of the lens and the capsule is much more earlier and stronger, and that's the reason why the chances of lens rotation are slightly minimized. So watch out for the eyes which have got bigger white to white ratios, and then maybe in those situations you can use this. So I always prefer to use the slit lamp marking over the freehand marking, just to enhance the accuracy and reconfirm by using an app. So either you can use an iPhone app, Toricam, or what we use is the Android phone, and you can use a Patwardhan iToric app. And I have found that the acceptability or the post-op accuracy is significantly better than your freehand marking. And even taking this the photograph and using the app, I prefer to do it on the slit lamp where the illumination is very good. And the third tip would always to be having a superficial stromal puncture, because even the ink goes off, you have the puncture for you to know. So with that, I think I'll conclude my presentation. I'd